Hello and welcome to the program. I'm your host, Neal Howard. On this Health Suppliers segment, thank you so much for joining us here today on Health Professional Radio. Our guest today is Dr. Sandeep Jani. He's one of the cardiovascular experts at the MedStar Franklin Square Congestive Heart Failure program. Now, one of their goals is to reduce readmission rates for current patients and provide them with some avenues to hopefully manage some of their health from their home. Welcome to Health Professional Radio, Dr. Jani.
Thank you for having me.
Give us a little bit of background about yourself and talk a little bit about your role there at MedStar.
Sure. I am an advanced heart failure cardiologist, which means that I train in cardiology and I also train in advanced heart failure. So I take care of the entire spectrum of patients with heart failure from new diagnosis all the way to heart pumps, transplants, or if need be, hospice. And I spend most of my time here at Franklin Square, but I also spend time at the other hospitals in MedStar that do advanced heart failure, such as the Washington Hospital Center, where they do LVAD transplants.
Now, CHF, congestive heart failure, it's kind of an all-inclusive term. Is that correct? Are there different types of CHF, or does it simply mean a congestive failure of the heart, regardless of what the cause actually is?
Right. So CHF is considered a syndrome, of which there are many, many causes. The underlying sort of things of it are that there are elevated pressures inside the heart, which often lead to shortness of breath and pulmonary edema and swelling and volume overload states. The causes of CHF are multiple, and the two sort of largest categories include patients with left ventricular ejection fractions that are low and patients with left ventricular ejection fractions that are normal or close to normal, yet still have volume overload states.
That covers a wide variety of CHF patients. In your program, part of managing this large volume of patients must take into consideration some of these patients coming back again and again.
The goals of the program are to try to keep people from coming back again and again, but broader than that are to give people better quality of life. And, there's lots of ways to do that. I think what brings both of these sort of populations together is making sure that they don't get volume overloaded or keeping them at sort of a eulemic state. And so the ways to do that include diuretics, but also it requires lots of monitoring from not just physicians, but nurses and mid-level providers and everyone sort of at home in clinics. And we have a diuretic clinic as well where we can do IV diuretics as an outpatient to assess sort of the fluid state. And that's probably the biggest thing that we try to do aggressively, both inpatient and outpatient.
How aggressively do you educate the patient on, I guess, the unique approach that MedStar takes to CHF?
As an inpatient, we have case managers and nurses who educate patients about how to monitor their fluid intake, what foods are high in salt, which will cause them to get fluid overloaded, how to weigh themselves daily, what to do if their weight's going up. So that starts as an inpatient. And then it continues. Those same nurse navigators or transitional care nurses call them as an outpatient, often with 3 days of being discharged, to follow up and see how they're doing and if they need, if things are going in the right direction or not the right direction, if they have appropriate follow-up in place, and if there's risks that are sort of identified at that time, they'll often come to me so that I can intervene at that time. In my clinic, I have a nurse who does similar sort of follow-up and tracks patients in terms of their weights and their blood pressures and their fluid status. The third thing I tend to do is I tend to allow patients who are able to and understand the concept to self-titrate their own diuretics so that if they gain weight within a few days, they can increase their own dose of furosemide or Lasix or whatever diuretic they're on to help sort of mitigate some of those issues.
Does your program focus more on the patient gaining this understanding of how to manage their health from home after discharge with proper follow-up? Or do you focus on the caregiver who's going to administer this care, making sure that they're properly instructed and that maybe they're the ones that will lend the patient some understanding? Or does it depend on the individual situation when they present at MedStar?
I think it depends on the situation. We try to do both. I follow many of these patients as an outpatient, but often, primary care physicians or other cardiologists follow them. We try to educate those physicians as well. Home health often follows these patients, and they have a heart failure monitoring program in place already. Mm-hmm. And then on top of that, we, aggressively try to educate patients on their own care. So we take all of those approaches as best we can.
Is there any support for some of the financial obstacles that may present themselves in individual patients' treatment journey from MedStar?
Well, to some extent there is. MedStar will often provide supplies of medications at discharge. They will sometimes provide transportation back to the physician or the diuretic clinic once folks are discharged. And MedStar has their own home health company that will help patients as well. So those are sort of the financial primary avenues I think MedStar take from a financial perspective, at least.
You talked about being involved intimately with the patient's case from diagnosis to treatment to discharge and then follow up at home. In your experience, what is the main factor that is the biggest stumbling block when it comes to managing your patient's care at home?
I think it's hard to do at home. I will say, I think, unfortunately, some of my patients just choose not to have home health or home care, or choose to come to the diuretic clinic once a week or twice a week or whatever they need to do. So that part becomes difficult. If they're willing to, engage with the program, I think most of the time we can keep people out of the hospital and living their life at home. The other aspect of our program that we haven't talked about yet is that because I'm trained in sort of the whole spectrum of heart failure, I am aggressive at figuring out when patients are approaching end-stage heart failure and will need implantable heart pumps or transplants if they're candidates, or starting to talk about end of life relatively early so that patients aren't suffering for months and months, prior to anyone having the discussion with them. So I think that's another aspect of the program that sort of is beneficial, that I sort of aggressively manage the severity of their heart failure.
When you're talking about the severity of their heart failure, do you find that sometimes patients already have some notion as to what they would like to do based on the way that their body has been behaving? Or maybe they've done some research on their own or have been advised by another physician, and the decisions that you are about to suggest, they're already on board with that. Does that make things a little bit easier, where you can skip some of the steps, some of the protocols, or is it normally by the book regardless?
Yeah, absolutely. I mean, if they, I think the first step is them understanding, where on the spectrum of heart failure are they, and some of them have a good sense of that, and some of them have no sense of that, depending on sort of, how they've been educated in the past, I would say. If they have a good sense of that, then it makes things significantly easier because they sort of know the next step's coming. The difficult patients are the patients who are either newly diagnosed or recently diagnosed and are end stage or close to end stage and have no sense of it at all. And you start talking to them about how sick their heart is, and unfortunately they're just taken aback totally. And that can be complicated and difficult at times. But we do the best we can. I do the best I can, at least, to try to educate where in the spectrum of heart failure they are.
Now, where can our listeners get more information about MedStar's Franklin Square Congestive Heart Failure program?
Well, there's a website that they can go to. Otherwise, that's probably the best way. I'll say that MedStar, owns 10 hospitals. And so Franklin Square is one of them, but there's 4 others in Baltimore, and there's several across Maryland and in DC. So the heart failure program that, I am at Franklin most of the time, but the heart failure program spans the entire system. And so I have a partner also in Baltimore. I have several partners in DC, and we all manage heart failure sort of as a team. So the MedStar website is probably the best place to look for those sorts of that sort of information.
Well, I'm glad that you decided to talk with us today, Doctor.
I appreciate it. Thank you.
You've been listening to Health Professional Radio. I'm your host, Neal Howard, in studio with Dr. Sandeep Jani, one of the cardiovascular experts at MedStar's Franklin Square Congestive Heart Failure program. Transcripts and audio of this program are available at healthprofessionalradio.com.au and also at hpr.fm. You can subscribe to this podcast on iTunes, listen in, and download at SoundCloud.